those are my disclosures. And so if you want to think about what really are the required biomarkers for advanced urothelial carcinoma, I will consider only European Medicine Agency approvals. I think this is quite a good basis, but also we have to consider, I think, the real life for the oncologist. I mean that sometimes the biomarkers are not strictly required, but they might help the choice. And so we will consider ADC, is immunohistochemistry necessary or helpful, focusing mainly on Nectin-4. For the immunotherapy, is PD-L1 status necessary, and FGFR inhibitors, which FGFR3 testing. And also, I would like to conclude by some diagnostic consideration. So first, regarding enfortumab vedotin, either associated or not with pembrolizumab, the target is Nectin-4. And as you know, in fact, this target is quite broadly expressed in urothelial carcinoma. And when you look at the subgroup analysis according to different thresholds of Nectin-4 expression using immunohistochemistry, you see that there is no difference of effects. So strictly, regarding approval, there is no indication for Nectin-4 immunostaining prior to treatment decision. And that's over. Not completely. Because, in fact, several groups have reported that the Nectin-4 is not expressed in all urothelial carcinoma, and that it can be associated with certain histological subtypes or divergence. But the problem is that, first, we haven't a companion antibody available, so that all the studies that we are going to perform are based on other antibodies, so it's quite a caveat. And second, we don't know yet whether this absence of expression detected by our antibody impacts or not the response to EV pembro. So first, I would like to consider this study by a German group with Markus Eckstein, and they provided a nice study recording this lack of expression of Nectin-4 in certain urothelial carcinoma. So especially in urothelial carcinoma with squamous divergence, and also with in sarcomatoid carcinoma, and also in the neuroendocrine component associated with urothelial carcinoma. Also, if we consider the molecular subtyping, there is a decrease of expression in the basal subtype, which is one of the poorest prognostic subgroup. And so maybe we have to consider this in the future. And in these tables, which summarize, in fact, the expression of either Nectin-4 or TROP2, you can see that really there is a risk facing a urothelial carcinoma with a squamous divergence or sarcomatoid carcinoma to have no expression of Nectin-4, or maybe we can consider to help the decision performing the immunohistochemistry in these cases. And so this is an example of a case of a patient recently discussed in the National Tumor Board for Rare Bladder Cancer Disease in France. And so this patient has a mixed carcinoma with urothelial carcinoma with a glandular divergence, and also an endocrine small cell carcinoma associated. And so really there was a discussion between the board to give or not the opportunity to have access to EV pembro. And in fact, I performed the Nectin-4 immunohistochemistry, as you can see here. In fact, it is strongly expressed in the glandular pattern, but it is completely absent from the endocrine small cell carcinoma. And the patient was not treated by EV pembro in that case. And so to go back to the therapeutic impact of this absence of expression, other groups have reported this heterogeneous expression in some molecular subtypes, and also they have provided some indication using cell line that when you have basal cell line, you have a lower sensitivity to EV. So I think that we have to keep an eye on this and to aggregate, in fact, actual real-life data, in fact, to see in the future how to integrate this in the selection of our patient. Second, I would like to consider the immunotherapy. So this is a simplified view now of the treatment approved based on immunological checkpoint inhibitors. And in fact, this is very simple because at metastatic stage, in fact, you don't need to have a status PD-L1 to be assessed, either in second line, also in first line with EV pembro, or with the combination of nivolumab and gemcitabine cisplatin, and neither for the maintenance with avelumab. And so the only case when you need, in fact, to have a PD-L1 status is for adjuvant treatment with nivolumab, and you require a TPS above 1%. I don't consider in this slide, in fact, the whole options to provide for cisplatin ineligible patients with atezolizumab or pembrolizumab. In that case, we needed, in fact, the PD-L1 status, but I think that in the new therapeutic landscape, in fact, these options are not considered anymore. So another point I think it's important to keep in mind is that uropulmonary tract urothelial carcinoma can be associated with Lynch syndrome or have a mucosal instability. This is very well known, and as you know also, this is a reason, in fact, to have to consider, in fact, immunotherapy in that case. So I think that definitively we need to screen all urothelial carcinoma for Lynch syndrome, for MMR deficiency, and so on. So this is very important for the Lynch syndrome, but also it's important for the therapeutic decision. So I think this is a biomarker that has to be done for all urinary tract urothelial carcinoma. Last but not least, FGFR3 testing for advanced urothelial carcinoma. We discussed this before. This is a monotherapy which is indicated for the treatment of patients at metastatic stage when they have genetic alterations and after having received an immunotherapy. So this is the words from the EMA. And I want to go back, in fact, a little bit on this story. It was the prior director of my research team, François Rodvani. In fact, we discovered, in fact, this mutation in 1999 now. And you know it's this tyrosine kinase receptor, and with the mutations, you have this dimerization. And all the punctual mutations that have been discovered, in fact, leads to this dimerization and activation of the pathway. Another way, in fact, to activate the pathway is to get this dimerization using, in fact, a chimering protein. For instance, with the fusion between TAX3. TAX3 is like a glue, so you have this dimerization, and you activate also the receptor. But in fact, if you consider the genetic mechanisms leading to this protein fusion, in fact, TAX3 and FGFR3 are on the same chromosome, very close. So when you have this duplication inversion leading to the chimeric gene, in fact, this is on very short distance. So it means that in that case, the FISH technology will not be able to detect this fusion. And so FISH is not appropriate, in fact, to detect this alteration. So what is the incidence of these mutations? You know that they are very prevalent at the TS stage, more than 66%, less abundant in T1, 30%, and 12 to 50% in muscle-invasive disease and after in metastatic stage. And in fact, it is molecularly associated with strongly with the papillary pathway, the papillary luminal tumors. It is associated with some histological patterns. They are associated, for instance, with the large nest carcinoma or with carcinoma with inverted growth pattern. And it's on this slide you can see on the right a picture of a metastatic lymph node who keeps, in fact, this pattern. But in fact, we cannot rely only on the histological pattern to screen for the FGFR3 alteration, and we have to do for all, I think. And also to keep in mind, and it was also related to the prior case discussed in the satellite symposium. In fact, the FGFR3 mutations are quite more frequently encountered in the urinary tract. And so the opportunity to target FGFR3 in urinary tract urothelial carcinoma is quite more important than in the bladder. So keep in mind this when you consider the therapeutic option. So what are in fact, the tools to detect this mutation? So we have to consider that we have to detect either DNA punctual mutations, but also fusions. And so we have the kits from the TERA screen. So it's basically it's a RT-PCR, so targeting some of the fusions and the most frequent punctual mutations. So it's not so expensive, but in fact it's very difficult for the lab to implement this because it will require a technician dedicated to the technique. And so we prefer, in fact, to use a generic NGS approach, which are more expensive. We perform, in fact, basically a DNA-seq, and also we use a kit for the fusion as in other organs. So some recommendations in practice. First, I think that, as I mentioned, even if these mutations are frequently associated with inverted growth pattern or large nest, it has to be done for all urothelial carcinoma when Elafitinib option is considered. And in my hospital, in fact, we do it for all patients at metastatic diagnosis. The immunohistochemistry currently is not sensitive enough to be used as a surrogate marker for genetic alteration. It means that if you perform immunohistochemistry with FGFR3 and screen only the positive case, you're going to miss patients. So I think that maybe it's going to be improved in the future, but currently is not appropriate. FISH definitively has not to be used in that context. And so let's do, in metastatic settings, the molecular test using either metastatic tissue or always the invasive part of the primary tumor. So it's very important because, in fact, as you know, the bladder cancer is multifocal. So the upper part are papillary tumors. They are very frequently associated with FGFR3 mutations, but it can be that in the depth, in fact, this is another tumor with no FGFR3 mutation, and this is the deepest part of the tumor which is going to lead to the metastasis. So it's very important to study the most invasive part of the tumor. And last but not least, I would like to keep in mind that before, in fact, consider biomarker for a therapeutic option, we have to make the diagnosis. And in fact, so we do it by morphology and immunohistochemistry, but sometimes we have very poorly differentiated carcinoma, either with very locally advanced disease, and we have some doubt between, for instance, a cervix carcinoma or even a prostatic carcinoma and so on. And sometimes we have also metastatic presentation with an unknown primary. And now I think that in the context of these new therapeutic options, it's very important not to miss patients with the diagnosis of urothelial carcinoma. And in France, we have a national program, in fact, to make large sequencing using whole exome or whole genome sequencing or RNA-seq for all of these metastatic tumors with unknown primary. And in fact, now we have a good map of the mutation in that tumor. And for instance, if you have a third promoter mutation and an apobex in nature, you know, it's very suggestive of urothelial origin, and you can provide with all the treatment that we have considered now. And another option now that we are working on in Curie is to have a kind of library of RNA-seq for all types of tumors. And so we perform the RNA-seq, and after that we try to locate, in fact, the tumor in this library and to see which is the nearest neighbor. And in fact, it provides us with another evidence for the diagnosis. So to conclude, my key point is that for ADC, Nectin-4 and TROP2 immunohistochemistry are not regulatorily necessary, but could be of interest for some histological subtypes to help treatment decision. Obviously, for HR2, it's required. For immunotherapy, I think that no PD-L1 status necessary. I think that definitively mismatch repair should be addressed for upper tract urothelial carcinoma. On FGFR inhibitor must be searched both at RNA and DNA level for mutations and fusions. And keep in mind that it's very important to now to decipher beyond unknown primary tumors, those which are associated with urothelial carcinoma. And thank you. Muchas gracias.